I think there's been kind of a big shift over the last 10 years in how we think about surgical epilepsy. It really used to be either curative or palliative procedures, and temporal lobectomy has been shown to be one of the most effective treatments for epilepsy that is medically refractory, and really will improve the quality of life for somebody who has successful treatment. And then on the other end of the scale for surgical epilepsy has been really the vagus nerve stimulator, where we know that people will get I would say, significant reduction in the burden of their seizures, but virtually nobody is cured. And now with the advent of this visual aids or lit therapy, and with the advent of NeuroPace, we're now getting these kind of in-between treatments where it is potentially curative sometimes, more on the side of visual aids, and more on the side of palliative with NeuroPace. But we now have a whole kind of spectrum of interventions for surgical epilepsy that will kind of trade efficacy for reduction of side effects. And so Dr. Koh kind of covered the lid already. I want to talk about the responsive neurostimulator or NeuroPace device, which was approved in 2013. So just as an overall overview, this is a device that's implanted in the skull, and it has a battery, pulse generator, and then up to 2 leads that can be attached. And the idea is that the device is listening to the brain and figuring out when abnormal activity is happening, and then trying to stimulate the brain to shut down that abnormal activity before it spreads and creates a seizure. And if you look at the architecture of the device, basically has the implanted microprocessor with memory, digital storage and retrieval. We have the leads, which are used for both sensing and for therapy, and we have both a magnet and the PC and wand that can be used to interact with the device to either mark things in time with the magnet or to program the device with the wand and the PC. So here I'm going to talk about the 2 components. The first is the detecting component. Basically, we build a detector based on people's seizure activity that will be sensitive and specific for their individual seizures. And the detectors are made by 3 different things called half waves, line length, and area. These are features of the electrocardiogram that can be put together to build a specific detector for that patient. And we want to get a detector that will pick it up as early as possible. It also has a storage capacity, so we can store up to 32-minute channels of information. If we're recording 4 channels, we basically can get up to 4 90-second seizure events that can be stored and recorded and then downloaded to a laptop, so we can use that information to basically tailor therapy afterwards. And that ECOG storage buffer can be downloaded anytime. If it's not downloaded, eventually it will get overwritten, although you can then also sort of check things to be permanent storage. So let's say if somebody swipes a magnet, whatever's happening at the time that the magnet is swiped can be put into a reservation that will not then be overwritten. So basically it's a loop recorder with the potential to reserve slots for significant events that you can define. So now we have many people walking around with ambulatory continuous electrocorticography that we can then interact and examine their corticography as it's occurring from home. At any point, the patient can download the contents of their laptop, of the device to the laptop, and then plug in the laptop to the internet, upload it to a server where we can then look at their seizure activity within minutes after it's occurred. On the therapy side, we can use those same either depth electrode or strip to stimulate, and it's very flexible, 1 to 330 hertz, up to 12 milliamps of stimulation, up to a second pulse width, and we can use all 8 contacts of the depth or strip, as well as the device itself can as a contact. We can give up to 5 separate programmed stimulations, and each time it can change the stimulus. So if it detects a seizure, stimulates, and that stimulation hasn't stopped the seizure, it will then redetect and then can give a different stimulation, perhaps stronger or different parameters, up to 5 times. And then if it hasn't been able to stop the seizure by that time, it stops, waits for the event to be over, and then resets itself for another potential 5 stimulations. Each therapy, each of those 5, can be put into either 1 or 2 bursts as well. So oftentimes we'll have one electrode be one burst and then another electrode be another burst, so we can be more specific about which electrodes are getting what type of therapy. So this is sort of the idea of what we're trying to get here. I have 2 electrocorticograms. The top one is where the device is off, and the bottom one is where it's on. And sorry, it doesn't point very well, but basically we have the detectors on in the top here, and you can see that we picked up a little chirp, a little burst here, and the detector's gone off, the B2 detector, and then we're not stimulating, so the seizure has evolved over the next 10, 15 seconds. Then after the stimulation is turned on, this is the same patient, we have a similar type of burst. The device has recognized it, the B2 detector's gone off, it's provided a therapy, didn't stop initially, redetected a seizure, less activity here, another therapy, and then the seizure has essentially tapered off. So this is kind of the idea of what we're trying to get here, where we can turn on therapy, stimulate very early in what could potentially be a seizure, and try to prevent that seizure from ever occurring. Here's an example of one of our patients with bitemporal epilepsy, one of our most common types of implants, and you can see the device itself is implanted in the skull. It's basically, first we implant a tray, what's called a ferrule, where we screw it to the skull. You can see each of the screws, and then into that tray we then place the battery, and we'll kind of go over that in the lab this afternoon and talk about where to place the device. This is the pivotal trial that was used for FDA approval. There were 2 other trials prior to this, feasibility trial to establish safety, and the pivotal trial was really to establish efficacy and further look at safety. There were 32 centers, 240 patients. The inclusion criteria were essentially refractory, very difficult to treat epilepsy patients who had failed medication, 2 or more, and had at least 3 seizures per month for 3 months, and had their onsets localized to at least 1 or 2, at most 1 or 2 foci, and then were thought to be good candidates for surgery. So you can see the design here. We have patients are implanted and then given time to recover, and then they're randomized to either on therapy or sham therapy for 3 months. And then after those 3 months, everybody's crossed over into on therapy for what's called the open label phase. So it's actually a really, really well-designed trial, because the epileptologists and the patients had no idea whether the device was on or off, and there was no ability to perceive whether the device was on or off. So it really is a great way of conducting a study, a double-blinded study. Here you can see the demographics of the patients who are included. These were a third of patients had vagus nerve stimulator and failed, 60% had undergone intracranial monitoring, 32% had previous epilepsy surgery already. And so these were really the toughest of the tough surgical epilepsy patients who were included in this trial. If we look at the pie graph here, it shows kind of the breakdown of where we implanted these stimulator leads. Over half of the patients were hippocampal in origin, so 50% were purely hippocampal or medial temporal lobe. Another 8% were hippocampal plus neocortical epilepsy, and then the rest were basically everywhere else. The occipital was the most poorly represented part of the brain, but this basically follows similar types of numbers in terms of who we operate on for surgical epilepsy as well. If we look at the underlying imaging abnormalities for these patients, we can see that a third of the patients had MRI normal epilepsy, a third of the patients had hippocampal sclerosis, and then the other third were basically everything else: stroke, dysplasia, encephalomalacia. If we look just at the mesial temporal lobe patients, we had 69 that were included had bilateral mesial temporal lobe epilepsy. 17 had implanted on the left medial temporal lobe, and 9 on the right. So obviously there was a favoring towards the dominant temporal lobe epilepsy. Here's the month-by-month breakdown during the blinded phase of the trial, and you can see the top group here are the sham treatment group. So you can see after implantation, everybody's seizures decreased, and we had seen this in the feasibility trial. It was also seen in the Sante trial for deep brain stimulation for epilepsy. Anytime you do a surgical procedure to a patient who has epilepsy, chances are they're going to have a decrease in their seizure frequency for a while afterwards. And then if you follow them month by month, they then separate. You have the patient, the group with therapy on, trending downwards in terms of their mean seizure counts, and the patients who had the therapy off essentially got back to their baseline level of seizure frequency by the third month of the blinded phase. So if we include all those 3 months together and we look at just total seizure counts during that time, we see that the sham stimulation patients had about a 17% reduction in their seizure on average over those 3 months, whereas the responsive stimulation group had about a 38% reduction in their seizure frequency. That was again in those first 3 months. You can, looking at the neuropsychological and affective status of the patients after these 3 months of the blinded period, there was basically no difference between the blinded on and blinded off groups with neuropsychological function or mood. When we then looked at the open label phase at 1 and 2 years out, we saw statistical improvements in verbal fluency, visual spatial processing, and memory as well, although this was patient-reported and neuropsych testing. You can see here that there were also improvements in quality of life results at year 1 and year 2, but again, this is during the open label phase, so this is not as well controlled. If we look at serious adverse events from all the trials, so that includes both the feasibility trial and the pivotal trial, we see that there's a serious adverse event rate of about 4.3%. That includes extradural hematomas, subdural hematomas, cerebral hemorrhage, and traumatic intracranial hemorrhages. This was felt to be favorable compared to the deep brain stimulation cohorts, which it was compared to for the purposes of FDA approval. If we look at infection rate, this is after the pivotal trial. We also have some longer-term outcome results now. There's about a 6% serious infection rate, with 8 of the 15 infections resulting in the patients having to have their device explanted. So here we're just kind of looking at whether or not there was any difference in the outcomes depending upon what the stimulation parameters were for these patients. And we can see that for the hippocampal patients, there was a little difference in terms of one frequency, 200 hertz versus 100 hertz compared to the neocortical group. We're also looking for any kind of therapy, any kind of stimulation parameters that might be associated with an improved outcome. And you can see here, this is just one patient for whom, and this has been, I think, generalized in many other patients as well. You can look at the solid line here is the seizure rate, and then the red lines here are the total number of detections, and the red are the therapies. And you can see that in general, as we increase the number of therapies, we see a decrease in the number of events. And so we do believe that there is a clear correlation between the amount of therapies and the reduction in seizure amounts. And so most patients who are being stimulated today have many more stimulations than they would have had seizures. So if they have 3 seizures per month, they might be getting 1,000 stimulations per day. 99.9% of those probably would not have resulted in a seizure. But again, we know we want to stimulate as early as possible, and we're not sure whether there could be a cumulative effect of the stimulations. So in conclusion, the primary endpoint was met for the pivotal trial. There was a significant seizure reduction in the stimulation group compared to sham, low serious adverse event rate, and the open label experience does show up to about a 60% reduction in seizure over a number of years, and so it was approved in 2013 by the FDA. And here's just the approval letter. They basically approved with the exact same indications that were included for the trial. So that same kind of group of patients who have failed more than 2 medications, had more than three or more seizures per month for 3 months. Since then, there has been a paper coming out in 2015 looking at the long-term results in these patients. And so basically, we included the patients from the feasibility study, that was 65, and then all the patients from the pivotal study, 191, followed them in what's called the long-term treatment study, and then looked at their seizure outcome and adverse incidents out as long as 6 years now from that. And basically, this just shows that the demographics are very similar between this group and the original pivotal study. And if you look here, we've kind of broken it down by year. So patients that have had it 3 years or more of treatment versus at the bottom 6 years of treatment. And you can see that the percent reduction of seizures has remained pretty consistent throughout year 2 to year 6. Even out at year 6, we have about a 65% median reduction and about a 60% responder rate, meaning that they've had a 50% or greater reduction in their overall number of seizures. And there is definitely a group that drops out. So there are people who, for one reason or other, drop out of the therapy. But with this analysis that we use, basically a last result carried forward. So whatever their rate of seizures were when they dropped out, then we consider them to have that same rate forever on afterwards. And this is the long-term serious adverse events table here. And you can see that the implant site infection is by far the biggest group here. There's about a 9.2% infection rate, and in patients who have gone out with a mean follow-up of about 5.4 years now. And a lot of this is because many of the patients have to undergo multiple battery revisions over a 6 or 7 year time frame after implantation. If we look at the number of patients with complete seizure freedom as part of this long-term follow-up study, we can see that there are basically no patients that have had no seizures after implantation. So these are very, very poorly controlled patients to begin with, and every patient has had a seizure at some point. If we look at the last year, then we have about a 13% seizure-free cohort. If we look at the last 3 months only, we have a 16%. If we look at any 6-month period during their participation in the trial, we have a 23% seizure freedom rate. And if we look at any 3-month period, we have about a 37% seizure-free rate. And so I think every center, certainly our center, has a cohort of patients who are almost seizure-free, if not seizure-free, and then pretty much all along the spectrum of seizure control down to basically non-responsive as well. So we're also learning a bit more using this NeuroPace device. It can not only be used to treat epilepsy, but it can also be used to really find out more about a patient's epilepsy. So this is a study that David Spencer down at OHSU and I conducted, just looking at 6 patients who had undergone bilateral hippocampal depth electrode placement with the NeuroPace, and found basically that patients have a very variable amount of seizures on one side versus the other. Typically, we bring people in for epilepsy monitoring and try to get 3 or more seizures to figure out whether they're unilateral temporal or bilateral temporal. But we saw in this study that there was a patient that had 12 unilateral seizures before then having a seizure on the other side. And so we're really seeing with this long-term chronic ambulatory monitoring that our short-term monitoring in the epilepsy monitoring unit is really not sufficient to make a decision about whether somebody has bilateral temporal lobe epilepsy or unilateral temporal lobe epilepsy. And here's another paper that was published 2 years ago now from Rush, where basically they looked at 5 patients who had the NeuroPace device and didn't work for them, but the NeuroPace gave them enough information to then make a surgical decision and go back and do a surgical resection. And 4 out of the 5 patients who went back for a surgical resection afterwards are so far seizure-free after that. So clearly the NeuroPace, even if it doesn't work, can give us more information about how we might approach them from a surgical standpoint. So just looking at future directions for NeuroPace, and I would say, neuromodulation for epilepsy in general, we need to validate the markers that we use with this device. So we're able to save now events on this device. We don't know if they're clinical seizures, but we can capture what's called long episodes or events that last longer than, say, 15 seconds or 30 seconds. We can capture when the amplifiers are saturated, which happens sometimes in patients with severe seizures, or episodes where the detectors have gone off for a long period of time. We can save those and use those as surrogate markers for their epilepsy, and I think that will be very valuable in the long run in following patients with epilepsy. I think we need to examine different protocols for stimulation. This is really a responsive neurostimulator, so there's essentially no continuous stimulation that's given with this device, but there's no reason to think that responsive stimulation in combination with continuous stimulation might have better results than intermittent stimulation by itself. And then we need to figure out, which parameters are the most effective for this device as well. But and right now we're only stimulating in limited number of nodes of the network, particularly in temporal lobe epilepsy. We're essentially stimulating in the amygdala and in the hippocampus. As you know from all of our lectures here today, the limbic circuit is much larger than that, and so this will give us an opportunity to see whether or not there are other nodes within that limbic circuit that we might be able to use more successfully than the ones that we've investigated so far. And then the last question that I have that's very interesting is whether or not, again, there may be a disease-modifying aspect to the stimulation. We know that for patients with vagus nerve stimulation that their seizure control actually improves for up to a year after the stimulator's turned on. We're seeing a similar type of phenomenon with the NeuroPace, where patients who are 2 years out are doing better than patients who are 6 months out. And the question is whether continuous or chronic stimulation makes that focus less irritable over time. And here's just an example of one patient in whom I looked at an episode where we did not change any parameters and then examined their detection rate and found out that we detected events less and less frequently as time went on during that 84-day epoch that we looked at. So. And then this, again, is just a graphic to show the network nodes within the limbic system that we have not yet captured. There is a trial that has stimulated the anterior nucleus of the thalamus, sponsored by Medtronic, that did not meet their criteria and was not FDA approved. They're now going back to look and see if the FDA will approve it because there were some mitigating circumstances as to why they didn't meet their primary endpoint. And so whether it's anterior nucleus or whether it's mammillothalamic tracts or just the amygdala or just the hippocampus, I think there's a lot we still have to learn. So thank you very much. And